Okay. So after the lacrimal system, let's talk a little about the lid. And ptosis is one of the cases which I think is given almost every time in the exams, either as a short case or as a long case sometimes. So, and if you are well aware of the evaluation part, which I'm going to cover, I'm not going to go to the surgical part as it is going to be discussed post-lunch. So the evaluation part is more where the examiner stresses, because he knows as a MS candidate, you must have not done surgeries on ptosis, but the evaluation has to be a must. And if you want a result as good as shown in the picture of a ptosis surgery, you have to be very thorough with the evaluation part. So ptosis, as you all know, is nothing but the drooping of the upper eyelid. And to evaluate the ptosis, you begin first of all with the history. Onset, whether it is congenital or acquired, makes a difference because the management as well as the evaluation points are different, which I'll discuss. Laterality, again, whether it is unilateral or bilateral, the measurements will vary. The way you have to measure, again, we'll be discussing. Progression, if it is increasing, it goes in favor of CPEO. If it, and generally congenital ones may be constant, and the acquired ones, if they are there, they might show a decreasing pattern also. Variation, diurnal changes goes in favor of myasthenia. So as soon as you get a history of diurnal variation, immediately it should strike your mind. Any allergic reactions or drugs which are causing edema, which can lead to a pseudotosis, should be asked and kept in mind. Any medical history and family history for certain conditions, again myasthenia, CPO, etc., which may be helpful. Any association in history with the jaw movement. As you know, there's a phenomena, Marcus Gunn we'll be discussing, that goes in favor. The patient will give you history that whenever the child is moving or chewing, the eye is flickering. Abnormal ocular movements, as you know, double elevator palsy can be associated with ptosis, strabismus in other forms can be associated, and that alters the management again. So that has to be asked. Abnormal head posture, especially in bilateral ptosis, you'll find a chin lift, you can find a face turn also, so that history is very important. Trauma or previous surgery may be the cause of acquired ptosis. Use of steroid drops. Post-cataract surgery ptosis, one of the most common causes is use of steroid drops. You can be asked in exam what are the other causes of post-cataract surgery ptosis. It can be trauma by the superior rectus fossa, eponeurotic trauma. All these can be the causes of post-cataract surgery ptosis. Any bleeding tendency, so that you are prepared on the surgery table. Dysphagia, dysphonia, dysarthria again goes in favor of myasthenia. So all these aspects you have to be very careful while taking your history. The psychological aspect, very important, because it will help you in deciding the timing of your surgery. Sometimes the child may be having a mild or moderate ptosis, not causing amblyopia, but the peer pressure is so much that he's developing depression or whatever the reason. So you should consider that also. And some are very casual, so they go on for a longer period. So psychological impact is one factor. And again, the photographic documentation. Ask the parents to get the photographs. If they're adult, they can show you their photographs. Nowadays, we have so good access to photographs. You should have a documentation pre-op so that you are able to explain later on. Never overlook the basics. Visual acuity, very important, because you know ptosis can lead to amblyopia due to two causes. Either it is severe ptosis leading to disuse atrophy, the eye is not being used, or it can lead to meridional amblyopia also due to the weight of the lid. So you have to be very conscious about the visual acuity. It should not be that you have operated and the parents say that the surgery has led to the diminution of vision. So very important to have a pre-op assessment of the vision. A cycloplegic refraction must. IOP, fundus, and you come to the measurements of ptosis. Yes, as we say, the eye sees what the mind knows. Unless or until you know that there is a term called pseudotosis, it will not strike your mind. So there are a number of causes where pseudotosis, like an enophthalmic socket in a thysic eye, in an enophthalmos with flow fracture, and very commonly lid retraction in early thyroid. For first year PG generally comes running, ma'am iski left eye mein ptosis hai. But when you see, it is the other eye that is having lid retraction, and that is not the ptotic eye. Even the parents will come and say ki iski yahan choti lag rahi hai. They will miss the point that the other eye has palpebral fissure is enlarged. So lid retraction is one of the very common causes of pseudotosis. So keep in mind, first of all, whether when you are starting assessments of ptosis, whether it is a true ptosis or a pseudotosis. Once pseudotosis is there, it is outrightly, the case is out. Then you go ahead with the true ptosis measurement. Now, when you appear for your exam, you have to have these points in mind for the Ptosis examination. Head posture, as I told you, as soon as the child enters your room, you can observe the head posture, history also, and your observation will help you. As I told you, bilateral ptosis will have chin elevation, or a unilateral ptosis can have a face turn also. Frontalis action, again, very important, because if patient is having severe ptosis, but a good frontalis action, it goes in favor that a sling surgery will be successful. So you can ask the patient to arch the eyebrows, and you can observe normal frontalis action is around more than 10 mm. So observation of the frontalis action is very important. Then eyebrow, there can be brow ptosis, so you have to be careful about that. Very important point which gives a cosmetic appearance to the eye is the lid crease or the lid fold. I'll come to that in detail. So presence of a good lid crease goes in favor of mild or moderate ptosis, or an absent lid crease may go in favor of a severe ptosis, and a high lid crease goes in favor of acquired ptosis. We'll discuss this one by one. Lid margin for any entropion, trichiasis, or any other marginal abnormalities. Then the most important points, two most very important measurements which help you in measuring the amount of ptosis is the palpebral fissure height and MRD1. So palpebral fissure height, horizontal as well as vertical. Practically we go for the vertical one, but in some cases like in blepharophimosis, the horizontal measurement is very important. Vertically also take care that you check in the primary gaze, up gaze and the down gaze, though the measurements practically we would use for the primary gaze. Coming to the MRD1, the distance from the upper lid center to the corneal light reflex, very important, we'll discuss. MRD2 is the distance from the corneal light reflex to the lower lid, and normally the PFH should be equal to MRD1 plus MRD2. Then, so amount of ptosis can be measured by two methods. I'll tell you which one is better, MRD1 or the PFH. Then you come to the 3L, the levator function, another very important factor, because that is going to be the decisive factor of your surgical option. Lid lag, a very common feature in congenital ptosis but absent in acquired ptosis. Lid lag is that when you look down, the lid does not follow the globe because it is dystrophic LPS is there in congenital ptosis. Lag of thalamus, because your surgery is going to lead to some amount of lag of thalamus. So any pre-existing lag of thalamus should definitely be noted, because that's going to increase and you should be aware of that. Bell's phenomena, Marcus gun jaw winking and ellipse. The three phenomena very important, because your management is different, and if it's a poor Bell's phenomena, it's a poor prognostic sign, you have to undercorrect. Marcus gun, altogether surgery is different, we'll discuss. And ellipse is done in very small children. Just to have a gross idea of the LPS action, you just invert the lid and ask the child to look in up gaze. The reverting back of the lid to normal immediately will tell you that it is grossly functioning normally. Extraocular movement to rule out strabismus. Corneal sensation, again, both Schirmer's and corneal sensation for any neurological deficit on cornea, or Schirmer's test for dry eye because they are bad prognostic features. Pupil, again, whether it is mydriatic, it could be a third nerve palsy, myotic in Horner's syndrome. So you have to have a look at the pupil, and of course the vision. So as I told you, you can again look at this: head posture, frontalis, eyebrow, lid crease, lid margin, PFH, MRD1, the 3L, then the three phenomena, three ancillary signs, and the pupil and the vision. Now, if you can remember this mnemonic, destiny, the few important things: the drooping of lid, E for excursion of the lid, the LPS function, S for the superior rectus function, tear film evaluation, ellipse test, Bell's phenomena and corneal sensation cover the neurological, and the Marcus gun by yawning. And again, there's three bad prognostic indicators known by the mnemonic BAD, where the Bell's is poor, cornea is anesthetic, and the dry eye is present. So these are bad prognostic. Either you undercorrect or you may have to avoid surgery altogether. Now coming to the actual measurements, frontalis, as I told you, you have to see the arching of the eyebrow. That gives you a clue that severe ptosis, you can go ahead with sling surgery. Upper eyelid crease, what is the difference between lid fold and lid crease? Lid fold is the one that we see in primary gaze, the fold that comes on the upper eyelid. And lid crease is measured when we ask the patient to look in the down gaze. So in normal values, you should be knowing female 5 to 8 and men 4 to 6. Absent lid crease, or as I told you, is a marker of a poor levator function, commonly seen in congenital ptosis. And a high lid crease is a marker of levator disinsertion, a very common cause of acquired ptosis. Then PFH, as I told you, it should be MRD1 plus MRD2, distance between the upper lid and the lower lid. Again, you have to know males 9 to 10, women 9 to 12. Upper lid should cover 2 millimeter below the superior limbus and lower lid just touching the inferior limbus. And accordingly, if it is a unilateral ptosis case, the difference between the PFH of two eyes will give you the amount of ptosis. But if it's a bilateral case, measuring the amount of cornea covered by the upper lid, and then we subtract 2 millimeters, that will give you the amount of ptosis, and we'll grade it mild, moderate, severe, depending upon whether it is a 2 millimeter, 3 millimeter, or 4 millimeter droop. Now coming to the very important aspect, MRD1, which as I told you is the distance between the upper lid margin and the corneal light reflex, normally 4 to 4.5. If the lid margin is above the light reflex, it will be a positive value. But if the lid is covering the light reflex, I'll show you how we check the MRD1. You have to lift it and see, and that will be labeled as a minus MRD1. And it is a sign of severe ptosis. As you can see in the pic, on there's a negative one because the reflex is not visible, and in the other you can see the reflex, so that gives you a positive. And then MRD2 has its own significance because it is the distance between lower lid margin and the corneal light reflex. Sometimes the lower lid may show retraction, and that is where the MRD2 role comes into play. I'll show you. Now, these are theoretical points. Your examiner may ask if he's an oculoplasty surgeon. MRD3 and MLD, these are generally not practically used, but MRD3 is the distance between center of upper lid margin and the corneal light reflex in extreme upgaze. The difference between the two eyes multiplied by 3 generally was used to calculate the amount of LPS that used to be resected. Similarly, MLD was the distance between upper lid to the 6 o'clock limbus, and the difference between this and two eyes again multiplied by 3. This is normally not being followed, at least I don't follow. Now coming to the measurement ptosis, as I told you, there are two methods, the PFH or the palpebral fissure height and the MRD1. See, in this example, suppose we take the primary gaze, right eye is having 10 mm ptosis, 10 mm palpebral fissure height, and left eye is having 7. So the amount of ptosis comes to be 3 mm. When I do the MRD1 test, right eye is having value of 5 and left eye is having 1. Now when I see the difference of the two, it comes to 4 mm ptosis. So, and as I told you, MRD1 plus MRD2 should be equal to PFH, that is okay. But now what to do? One is saying 4 and one is saying 3. So why is this reason? Your measurements are normal. You have made no error in your measurements. So what you see here is, just see that the lower lid is not touching the inferior limbus. There is lid retraction of the lid retraction on the lower side. So that is giving a more MRD2 has increased. In such cases, MRD1 will be the measurement that you will take. So MRD1 is definitely a more superior method for measuring the amount of ptosis than the PFH method. Otherwise, generally both will come same, but whenever there is such kind of situation, you will opt for the MRD1. Now coming to the levator function, as I told you, it is a very important test. Patient is instructed to look down, block the frontalis action with the thumb, ask the patient to look extreme down gaze to up gaze, and you grade 15 is normal, more than 8 is good, 5 to 7 fair, and less than 4 is poor. I'll just show you the method of LPS. See, in this case, if you elevate the eyebrow, this is a wrong method of taking the LPS action. Here you are pushing the eyebrow down. So again, this is again the wrong method of taking the LPS action. See, this is the right method. Just keep your thumb over the brow and give a posterior pressure. You don't have to take the eyebrow above or down. Be careful, and then you take it from extreme up gaze to the down gaze. Now coming to lagophthalmos, as you said, as I told you, lagos is the Greek word for hair, an animal which sleeps with its eyes open. And you must have seen in some cases it is physiological also, the inadequate closure, and otherwise it is facial nerve palsy. As I told you, post-op we can have lagophthalmos, so it is an important parameter which you should be careful about. Lid lag is the incomplete lowering of the ptotic lid in down gaze, more common in the congenital ptosis. Bell's phenomena, it is a protective reflex. As you know, efferent is by facial nerve and the efferent by the oculomotor nerve. We grade it. Normal is when the cornea rolls up and out. Inverse is when it rolls up and in. Reverse when it down and in. And perverse is when bizarre direction it is moving. And we grade it good, fair, and poor according to the amount of cornea that remains visible. And the significance of Bell's phenomena, as I told you previously, if it's a poor Bell's, it is definitely a bad prognostic sign. So you do either an because we cannot correct the ptosis and let the patient go into exposure keratitis and ruin the cornea. That will be more of a problem for him than the ptosis that was present before. So you have to be very careful in that. Ellipse test applicable in children, just a patient looks in down gaze, evert the upper lid, again looks in up gaze and immediately reverts back, so it shows that levator action is good. Again, this I'll just show you a comprehensive evaluation of whenever you have a ptosis patient coming to your room. Immediately as the patient comes in, check for the lid gaze. So you ask the patient to look down, you see that in the right eye, the palpebral aperture height increases. So this is the lid gaze. Now in the primary position, you just need a simple ruler. We are seeing the lid fold. This fold that is coming in primary gaze, measure the lid fold. Ask the patient to do down gaze and see the lid crease. If the lid crease is very faint, you can assess it in the other eye also, and measurement you can take. Now you take the palpebral fissure height from up to down. Then you come to the MRD1. Now in this you see that pupillary reflex is not visible. So what you need to do is elevate the lid and see for the reflex, and so the value will come to be minus 0.5 or 1, whatever it is. Then you see the MRD2 also. Coming to the LPS action. This is the LPS action from extreme up gaze to down gaze. And then we come to the this is your Bell's phenomena. You ask the patient to close eye. Both ways you can see, either in an open eye or with the closed eye. Bell's phenomena should be checked. Corneal sensation should be checked in both eyes. Schirmer's should be checked both eyes. And finally, after Schirmer's, you check the Marcus gun phenomena. So again, you check the Marcus gun phenomena. So now coming to congenital ptosis, as I told you, main signs were lid lag, lid crease faint or absent, LPS action decreased. Complicated congenital ptosis can be Marcus gun, blepharophimosis, and superior rectus weakness. Marcus gun, 5% of all congenital ptosis can have this. Fifth nerve and third nerve, you know it's a misdirection. And as the child opens the mouth or chewing movement, the ptosis will decrease. So there are two major groups. The external pterygoid levator and kinesis is the more common entity. In this, when the jaw is thrust to the opposite side, the Marcus gun phenomena occurs, or when the mouth is widely open, while in the internal pterygoid, lid elevates on teeth clenching. Then inverse Marcus gun is there, where instead of increase, the ptosis is caused by this. It is also called as the marine amat syndrome. However, it is debatable. Some people say the marine amat is because of the orbicularis muscle, due to the misconnection between fifth and seventh nerve, while inverse Marcus gun is due to fifth and third nerve. So it's a debatable, but in this, ptosis increases on opening the mouth. You have to grade the Marcus gun according to the excursion of the lid that happens less than 2 to 5 or more than 5, and accordingly, if it is a mild and patient is more concerned with the ptosis and not with the Marcus gun, you will treat him as a routine ptosis patient. But if it is the Marcus gun that is troubling him, then you have to, the surgery is altogether different. You don't have to go for a resection, you have to go for a excision of LPS along with a sling surgery. The blepharophimosis, it is a tetrad of blepharophimosis, that is the horizontal narrowing of the palpebral fissure. Ptosis, generally severe bilateral symmetric. Telecanthus is the increase in the intracanthal distance, and a skin fold that is present is epicanthus inversus. And associated symptom signs others may be there, and it is labeled type 1 if ovarian failure is there, type 2 if it is absent. So in extra examination, besides the routine ptosis examination, in this would be the horizontal palpebral fissure, the intercanthal distance, and the interpupillary. Normally, if our interpupillary distance is 60, the intercanthal is less than 30, so that you have a more than 2 ratio of IPD upon ICD. But in this telecanthus, your this ICD will be more, around 35, 36, and your interpupillary is still the same. So that will give you a less than 2 value, and then you know that it has. This is an operated case. You do it in 2 steps. First, the CU-plasty and the lateral cantholysis to increase the horizontal, and after 3 months, you can do the sling bilateral, or you can do it in one sitting also. Now, coming to the superior rectus weakness, rule of the thumb is that if there is a vertical strabismus associated with ptosis, you have to correct the vertical strabismus first, followed by the ptosis surgery. Although you will many times see that the patient is more concerned with the ptosis, because that is visible. Choti lag rahi hai, he does not know that much worried about his elevation deficit. But you know that you have to bring the eye in a normal position, then only you can have a good ptosis result. You cannot go ahead with this. Coming to the acquired ptosis, you have aponeurotic, in which comes the involutional and the traumatic, myogenic, neurogenic, and the mechanical. And acquired, you have few investigations extra. We have to be careful. Defects of levator aponeurosis occur in aponeurotic. Involutional is the most common. It can be post-op, blepharochalasis, habitual rubbing in patients of allergic conjunctivitis. As you see in this patient was having severe allergic conjunctivitis, and due to continuous itching, he has developed the levator dehiscence, and he has developed bilateral ptosis, and you see there is no lid lag, rather there is a lid droop in both eyes. So coming to the typical features are differentiating from congenital. There's a lid drop on down gaze. Levator function in congenital is decreased, but in this generally it is the good levator function. High skin crease because the levator has dehiscence has occurred and it goes up. So there's a high lid crease, and thinning of eyelid skin because aponeurosis becomes absent to the extent that you can see the underneath iris beneath it. So the difference, if you can be asked in your exam, the three differences between congenital and acquired ptosis. In congenital, in down gaze, lid lag will be present, while eyelid drop is present in acquired ptosis. Upper eyelid crease is poorly formed in congenital, but it may be higher than normal or absent in acquired. Levator function is reduced, while it is near normal in acquired. Coming to the myogenic, we'll cover the important ones.
Can you summarize, Dr.
Yeah,
Urmil?
myasthenia, it is generally, ptosis is asymmetric and maybe unilateral. Coggan slit twitch sign is a very important sign. The patient is asked to look down for a short period, and when it looks up, there's a sudden twitching motion. Then diurnal variation, the ice pack test, very important, you can do in the OPD itself. You will see that after applying ice for 2 minutes, the ptosis improves. The hydrophonium test, it is more of a diagnostic than therapeutic. IV drug is given, while in neostigmine, it is an IM drug. So it also shows, again, this is a seesaw ptosis. Again, it is seen because asymmetry is there in myasthenia. This is because of the Hering's law. You raise the more ptotic lid, the other lid will fall because equal innervation is going, but when you raise this lid, that innervation decreases and the other eye falls immediately. So this is the curtain sign. CPO, again, early bilateral, no diplopia is there, progressive kind of thing. Then myotonic dystrophy can be there. Third nerve palsy, ptosis plus restriction of elevation, depression and adduction is there, and mydriatic pupil is the clue for you. Horner syndrome, classical triad of mild ptosis, meiosis and anhydrosis. Along with it, you can remember this mnemonic, ample or sample, and you can see the findings of Horner syndrome. Very important in very mild ptosis or in Horner syndrome to do a phenylephrine test. If it shows improvement, you are sure that Muller's muscle is normal and you can go for a conjunctivo-Mullerectomy. Mechanical ptosis due to eyelid tumors, orbital lesions or cicatrizing conjunctival disorders or lid edema. Traumatic can be neurogenic. It's a Pandora's box. According to the etiology, you have to go for the management. Finally, the take-home message is that a thorough assessment is a crucial key point, and levator function is the deciding factor for the choice of surgery. Customized surgical solution is there, and never raise the hopes or the expectations of the patient too high before your surgery. Keep them low. You can give them a very good result and make them happy, but once you raise the expectations too high, it is very difficult to answer them. Thank you. Sorry for taking a little time, but the topic is so huge, and these are the patients of ptosis operated. So thank you so much.